alignment.
Yeah, I would have gone anterior as well. What's everybody's method for dealing with that dome or the surceal or the quadrilateral plate marginal impaction? What does everybody use for that? Because I haven't found a really good solution if it's really impacted.
So can you lower it down and do some bone graft there?
Yeah, yeah, bone graft. Yeah.
What's the articular impaction?
So whatever this has been done,
and you can put a plate
avoided
from the inside,
Yeah.
so that it will act as a very good buttress. And on that plate, which is fixed from the intrapelvic area, you can add one more plate by taking just lateral window of the ilio-inguinal approach and fix this fracture very well.
Yeah.
I think that is the way.
You guys don't have the striker system. Yeah, people have been telling me that, but they're making a new plate with a really nice plate that fits along the suprapectineal surface and a nice cage that comes down along the quadrilateral plate. And you can really push it up, and it's a really...
So will you do that, or will you do stopa?
Well, you can do it through the stoppa.
Okay.
You use this plate through the stoppa, and it's an intrapelvic plate.
Okay. I use the cervical plate, which is a that is called as a which plate? 6 holes. Cervical spine plates.
Oh yeah, okay.
H plate.
Yeah.
So that also can give good two punches onto the iliac superior ramus and buttress from the inside like that.
Yeah.
I think there's the same principle that plate.
It is, yeah. I mean, people would usually use the third tubulars or something coming underneath the suprapectineal plate. But that plate and the new one is just it's nice and stable and really good. It's easier to use.
Nirbhay, your comments?
I have been using, as I said, I was talking yesterday as well, I have been a big fan of the T-plate as well. So the lower end radius T-plate can be bent into a shape of a 7.
Yeah.
And as you could allow the long limb of the T-plate to push down along the posterior surface. The T part of the plate allows you to go along the anterior column, and which is buttressed by a secondary plate, something like this.
Yes.
And I found it a really useful tool because it's a thicker, slightly thicker T-plate will give you the adequate strength required, and the 7 shape will definitely also push it medially. I've been fairly happy with that, but then you need to be careful of exactly where you're placing the plate. A little far too medially and you're sunk, a little too laterally and the fragment will just come up. So the placement of that plate is, I think, is really important.
Yeah.
Yeah.
So last case before we go for the discussion, the patient came to me with this, with infection, with the flying out screws, with loosened out ischial tuberosity plate and disappearing head.
It's infected.
So, Dr. Kothadia, what is your take?
We have to go down, take out everything, implant everything, and then you have to, if at all possible, you can do a little bit excision of the head, put antibiotic beads, get over along with the infection, let everything get settled, and then I think he may need a THR in future.
What will like to do with the infection and the loosened plate? Operated twice before for debridement.
For me, it's always important when you have opened up, if there is still, if the instrumentation is really important for stability, and if the screws, they still have a good grip, and I know when I remove it, stability will be less, I even leave it in the first place. Yeah.
You even?
I even leave the instrumentation there in the first place, start with the debridement. I know I have to go back,
Yeah.
but I don't want to increase instability.
Yeah.
So that's, I think, an important point.
Brad?
But at the end, finally, it has to come out.
Come out. Brad?
No, I mean, I think I agree with everybody.
So when I opened this patient, that was frankly loose plate with there was quite amount of mobility was present, and the patient was having severe amount of pain. So what I did for this patient was this fixation with the, because there was quite amount of instability.
But it was
both
infected,
fragments
right?
both fragments were moving in and out.
But it was infected?
There was a granulation tissue.
There was granulation tissue.
So I excised the head, and after excision of the head, I could see the entire floor of acetabulum which was moving. So if I would have removed the head and there was unstable fragment of pelvis, it would have not united, or the infection would have not stopped also. So I put one locking plate, a small radius ulna plate from inside and one from outside.
So in certain situations, you have to do fixation. In the infection also, you have to do fixation.
Yeah,
That is the message which you like to give. Even though there is infection, if you want a stability, put the plate and screws and get a stability, and that will control the infection, I think. So.
No, I think that's a good point. I think my particular end game would be a total hip, like I think all of our end games is. And if that's the case, then, you know, I'd be inclined to be a bit more aggressive with the debris maw and, you know, cement spacer like you were talking about, or Prostelac, and then going back. But, I mean, you're right. Stability at the end of the day should help us get some bone stock at least.
And he was followed up for a period of 2 to 3 years. He was comfortable. He was having excision hip arthroplasty with united pelvis, and we called him two times for coming for THR. Patient was very happy with the excision. He was from rural background, so he was able to sit cross-legged with the shortening, but he never accepted a total hip replacement.
It's good.
Because he was at least 10 times operated before this procedure. So now we'll go for the first thing on the agenda, that is how to classify the radiology and how to classify the fracture acetabulum. It's a short exercise which everybody can participate. If they want to stop me, they can stop me. So everybody knows that there are Jude and Luteral classification and AO classification, but still all the pelvic surgeons use Jude and Luteral classification, which consists of basic and associated or complex classification. Basic, you have posterior wall, which is here. Second is posterior column. The entire posterior element is gone. Then, which is very rare. Then there comes the anterior wall and the anterior column and the transverse, which runs from back to front. So these are the 5 basic types of luteal and judate, and then there are 5 complex types. The first type, which is posterior column and posterior wall, you know. Then there is a transverse with posterior wall. Nowadays, because of high velocity accidents, this type of transverse with posterior wall fractures are on the rise. So they are the second largest amongst after the posterior wall. Then there are T-shaped when there is an involvement of obturator foramen or inferior pubic ramus, or it can be anterior wall with posterior hemitransverse or a bicolumn. When you see a bicolumn, then there is a separation of acetabulum from the pelvic rim, which is denominated by a spur sign. So if you see this, the spur sign, that means this is the fracture which is of bicolumn variety. So on simple X-ray, you will like to see all these 6 things even on pelvis with both hips, AP X-ray, even if you don't have a Jude view. So you can see a teardrop, you can see a dome, you can see a posterior lip, iliopectineal line, ilioischial line, and anterior lip. So in fact, all 6 things you can see on this AP X-ray, and then you can differentiate between anterior or posterior furthermore by doing a Jude views. So on simple AP X-ray, you can first trace the iliopectineal line. This is the iliopectineal line coming towards the pubic symphysis, and if it is broken, that means the anterior column is involved. So just by seeing this line, then you can see that the anterior column is involved. Then there is the anterior rim which follows the inferior pubic ramus, inferior part of the superior pubic ramus, and if you see that if it is broken, then its anterior lip is also gone. You have to see ilioischial line. When you see ilioischial line, then it compromises the posterior column. If the posterior column is broken, the line is broken, that means it is a posterior column. Another thing you can see, which is in continuation with the ischial tuberosity, that is posterior wall, and if it is broken, then it is a posterior wall fragment. And in the end, you have to second last, you have to see the teardrop, and if the teardrop is displaced or is deformed, that means there is an injury which is medialized the pelvis. Also the dome, which you have to see, if the dome is fractured, then the weight bearing surface is affected. So all these things, knowledge you can gather by doing a simple good AP X-ray. So then you can go for a obturator oblique, which is 45 degrees oblique. You can see when there is a obturator oblique, you can see the obturator foramen completely, and a long, nice iliopectineal line which consists of the anterior column and the posterior wall. Similarly, you can take iliac oblique, where the complete iliac bone is seen, and hardly you can see a obturator foramen, and you can see that this is a posterior column and the anterior wall. So all these lines are very important on simple X-rays. You can first start with, always you have to first think of iliopectineal line. Any X-ray you see, first, even don't see any other thing, first see iliopectineal line. If iliopectineal line is intact and there is a fracture, then you should think that everything is posterior. So posterior wall, posterior column, or combination. Then you can see ilioischial line. If ilioischial line is intact and there is a fracture, that means it is a posterior wall. If intact iliopectineal line, intact broken ilioischial line, then it can be a posterior column or it can be a posterior column with wall. So this will tell us if there is an intact iliopectineal line. So with the intact iliopectineal line, you can have three types. One is posterior wall, one is posterior column, or posterior column with posterior wall. When iliopectineal line is broken, then remaining 7 types. You can have broken, then you can have anterior wall, anterior column, transverse, transverse with posterior wall, T, hemitransverse, and bicolumn. So ilioischial line is broken, you can, ilioischial line is intact. Now iliopectineal line is gone. So for, you have confirmed that this is the anterior side is involved, and ilioischial line is intact. So everything is all anterior. It can be anterior wall or anterior column, or it can be only anterior wall. So pubic extension is present, then it is anterior column. If there is no pubic extension, then it is anterior wall. So next scenario is remaining 5, which are the complex ones. So both lines are broken. So iliopectineal is gone, ilioischial is gone. So you have remaining transverse, transverse with posterior wall, T, hemitransverse, and bicolumn. Then you have to see obturator ring. If the obturator ring is intact, then it is transverse. If the obturator ring is intact with the posterior wall, then it is transverse with posterior wall. When there is obturator ring is broken, then you have only 3, that is hemitransverse, T, and bicolumn. Then you have to see a spur. If the spur is present, then it is bicolumn. And if spur is not present, then it can be hemitransverse or a T, and sometimes the CT scan is needed to differentiate between the two. Sometimes it is interlinking. So nowadays there is another complex situation is coming, that there is a bicolumn with the posterior wall. So that is also been reported in literature, that there is a bicolumn with the posterior wall is there, so making life more difficult for approach for such patients. So few exercises for you. So for your benefit, I have put all this lower down, all the 10 types, and these are the X-rays for you. So what do you think? So you can have posterior wall, posterior column with wall, or a posterior wall plus transverse, or a T fracture. So what do you think? So come on, what is this?
It's like posterior wall to me.
What is this?
Ilioischial.
So both are intact or absent?
Intact.
So intact. So there is some fracture which is seen, that means what it is? So it's a posterior wall fracture. So just looking at the simple pelvis with both hips AP, you can have a posterior wall. So this is another example for you, which is a pelvic 3D. So this is showing a PBH. This is the involved part, and this is another view of this fragment, and anteriorly is not seen. So what do you think? What anteriorly is involved or no? It's not involved. Posteriorly involved? Yes or no? Yes. So it's only wall or column? Column and wall. So look at this again. So anteriorly it is not broken. So you have to have only three options. So ilioischial line is also broken and wall is also there. So it is posterior wall plus posterior column. So it remains as a posterior column plus posterior wall. Another example for you. What do you see on this iliopectineal line? Broken or not broken? Broken. So is it pure posterior? It can be posterior wall with column, posterior wall. Is it possible? No. Whenever you see an anterior iliopectineal line broken, so cannot be having a pure posterior wall. So whatever actual posterior wall and posterior column is not there. What do you see here? Posterior wall. What do you see in ilioischial line? Intact. So let's go. So iliopectineal line is broken. Okay. Ilioischial line is intact or broken?
Broken. Broken.
Broken. And obturator ring is intact or broken?
Intact.
So it's not properly seen, but I can give another view here. So iliopectineal line, ilioischial line is broken, plus there is a wall, and this is the intact obturator foramen. So now for you, the scenario is iliopectineal line is gone, ilioischial line is also broken, and there is a posterior wall, and there is an intact obturator foramen. So what it is? The options are for you mentioned here. What it is? So it is a transverse with posterior wall. Because iliopectineal line is broken, so pure posterior is out. Ilioischial line is broken, so remaining 5. Obturator foramen is intact, so it becomes transverse with posterior wall. So this is how you should identify the fractures, and these are helpful for your approach selection. Another patient, what do you see here? Which lines are broken? Which has to seen first? Iliopectineal line is broken, so pure posterior is out. Ilioischial line is broken. It's the fracture is going to the ischial tuberosity. So pure anterior is also gone. So pure posterior, pure anterior is gone. So remaining 5. You have to differentiate between transverse with posterior wall, T, and hemitransverse and bicolumn. So what do you want to see next? Obturator foramen. See this obturator foramen for you. It's intact. So it remains transverse or wall. Is there any wall piece there? This is the wall piece. So it becomes transverse with posterior wall for you. So just by looking at X-rays and a few CT scan, you can classify. So another patient for you. What do you see here? Iliopectineal line. Broken. Ilioischial line. Broken. Then what do you see? Obturator foramen. What do you see here? Broken. So, and in the end, what do you see here? Spur. So, stepwise, first iliopectineal line gone, pure posterior out. Posterior ilioischial line is broken, so pure anterior is also out. Obturator foramen is out, so pure transverse is out. Then remaining T, hemitransverse or bicolumn, but you see a spur, then it becomes a bicolumn. So friends, this is very essential to see all X-rays very carefully. What do you see on X-rays? And you can have this. So this is another example where I was mentioning that there is a iliopectineal line broken, there is ilioischial line broken, there is obturator foramen which is broken, and there is a spur sign, and there is a wall. So this is a subtype of bicolumn which has been described nowadays, that there is a bicolumn fracture with the posterior wall, becoming life very difficult for approach. You need to open from both sides, or sometimes those who are very confident, you can go ahead and do this with extensile approach. The last example for you is this. What do you think what it is? So this is the opposite side, the right side is our and this is the fracture line which is seen only on the simple X-ray. First, you cannot identify, then at least what you can identify is ilioischial line is intact. Okay?
That's an anterior column.
Iliopectineal line is broken. This is iliopectineal line going to the pubis, and it is broken. Ilioischial line is intact, so remains anterior wall or column. There is an extension to pubis and the column, so it is an anterior column. So here you can see the CT scan going from the very high anterior column fracture, and this you can identify whether this is anterior column or posterior. So friends, this is an important algorithm which you can all follow. This simple four things on the X-ray. First, iliopectineal line. Second, ilioischial line. Third, obturator foramen. And fourth, spur sign. So if you think only four things you see on the X-ray, you can nicely classify the fracture, and you can simplify your approach, which approach to be